minutes to get here. But that said, I will start with our prerequisites and let you know that next, because we're at the 4th of the month, we have another one coming up just next week on June 2nd. Our June nursing grand rounds will be on alternative therapies. And so we have some great speakers. We have our own Annie Parker speaking on healing touch. We have Ann Ramsey, who many of you may know, speaking on acupuncture and Chinese massage. And we have Lorinda Poirier-Solomon speaking on shiatsu and I guess it's called shiatsu body work. So 3 great alternative therapies often used in conjunction with our own more standard modality. So great presentation coming up. That will be Thursday, June 2nd at 8 a.m. in Austin Auditorium. And then later in June, we will be having trauma topic coming up on June 23rd. We still don't have the details on that, but we'll be sending out information as soon as we do. And then coming up in July, Donna Sheequin from our emergency department, one of our nurse educators, will be talking about summer emergencies, things that they frequently see in the ED, and of course the prevention thereof. So some great things coming up in the next 3 nursing grand rounds. And that's it. I think we'll get started. So thank you. We appreciate your joining us, and particularly a welcome to our outside sites at Alice Hyde, St. Johnsbury, and Central Vermont Hospital. Welcome. And as you know, this is the month of May, which is Stroke Prevention Month. And so we have Ruby Merali with us, who is our stroke prevention nurse. And we just had our conversation. I guess we'll officially say she's no longer our new stroke prevention nurse. Ruby has been with us just about a year now. So we welcome her. I know many of you heard her speak in January. And again, talking this time very specifically about stroke prevention, what we're calling what every nurse should know, and certainly I know not all of us here are nurses, what everyone should know, and important things to know about stroke prevention. So thank you, Ruby, and welcome.
Thank you very much. Can everybody hear me pretty much okay? No, not yet. Okay, how about now? Good. Sorry, it's always a tricky thing playing up here with this, so I apologize. Sometimes I tend to be a little bit soft-spoken unless I'm yelling at my kids, which hardly if ever works anyway, so. Is this a little bit better? Lost. Here? Nope. Okay, is this good? That's very good. Okay, wonderful. Thank you very much, Fern, for that kind introduction. Like Fern introduced, I am Ruby Merali. I'm the neurology nurse practitioner and not so new to the group anymore. I will have been in my position for about a year, and it's a real honor and privilege to be invited once again to do nursing grand rounds and talk to you, my nursing peers, about stroke and stroke prevention. More so for the month of May because it's Stroke Awareness Month, and also just last week we also had Neuroscience Nurses Week, and I'll talk a little bit towards the end about some of the wonderful stuff that the stroke team did as far as education, community outreach, with efforts to bring awareness to Stroke Month, and also to really put stroke education and stroke prevention out there. So we'll get started here, and I have nothing to disclose except for this is a call for action. All nurses, all clinicians, all healthcare providers should be aware of stroke education and stroke prevention measures. So for those of you who know me, is that pretty good? Okay, perfect. Can everybody hear me?
Louder.
So as all of you know, many of you may have heard in the past, I am a big fan of my own personal nursing mentor, Florence Nightingale, and one of her favorite quotes that I've kind of adapted in my own personal nursing practice is, I think once feelings waste themselves in words, they ought all to be distilled into actions which bring results. And I think nurses are quintessential in bringing action in lives of patients. So we're all going to get really involved in getting educated about stroke, and hopefully you all will help prevent strokes for your patients. So the roadmap for the next hour or so will be pretty much a look at stroke, what is a stroke, a quick review of the pathophysiology of stroke, and then what really should we know about stroke, some of the stroke risk factors, modifications to prevent stroke, And we'll talk a little bit about Life Simple 7 and the stroke risk scorecard. So just a show of hands, and we're not going to hold this against you at all, because I promise when you leave from here, if you do not already know about these two tools, you will. Who knows about Life Simple 7? Just a show of hands. Okay, Kathy Gregory. Guilty. Okay. Anybody know about the stroke risk scorecard? All right, still 3 people. I see 2 avid neuroscience nurses and our IRIS research coordinator there. All right, well, I promise you, you will know 7 simple things about how to prevent a stroke, and you will know about the stroke risk scorecard before you leave today. So that's wonderful. All right, so what's the buzz really about stroke, really? So every year it's the third leading cause of death after cardiac disease and cancer. And I was actually reading the new 2011 circulation that I got from the American Heart Association, and what they were noting, and I alluded to find on their website, was actually the incidence of stroke is actually declining to put us a little bit further down. However, the mortality rates are still there. So that's very interesting. We're getting better at catching the strokes and preventing them, but we're still up there as far as mortality rates go. It's always shocking to see about 795,000 people experience a new or a recurrent stroke. And then women tend to have more strokes than men. We tend to live longer, so with each decade of our life, we're at a higher risk for having a stroke. After the age of 50, we tend to lose our best friend estrogen. That puts us at a higher risk for having a stroke. Also, women, we are childbearing. We tend to take oral contraceptive pills. We may be smokers. That generally puts it at a higher risk for having a stroke because of those factors as well. The incidence of stroke every 40 seconds, every 3.1 minutes. Now, when we compare that to how often we hear about people coming to the emergency department with chest pain, that's quite dynamic, because a lot of times when people will present with stroke-like symptoms, there's not really that flurry of getting them 2 quick interventions. Having worked as an ER nurse, I can say to that, because you come in gasping for air and you have your hand over your left upper chest wall, I'm going to jump on you. But if you come with diffuse complaints of I don't feel well, I can't see too good, I'm not sure, I don't feel quite right, my right hand is numb, I might be a little bit slow in triaging you to get you to the bedside. So that's very interesting. And then unfortunately, stroke is one of the leading causes of serious long-term disability. We have 4.7 million stroke survivors. So unfortunately, stroke's just not killing us anymore, but we have to live with the aftermath of having experienced a stroke, which can be quite debilitating for some people. I want to have you take a quick look at this picture and really pay attention to the faces of stroke. It's no longer a disease that afflicts the elderly. Very young people tend to have strokes too, for many significant reasons. So what exactly is a stroke? It's defined as a neurologic syndrome that occurs in a particular vascular territory which has lack of blood flow and oxygen. So if it's your left frontal lobe, which controls your speech area, if you take a hit in that region and you have a blood clot that occludes blood flow and oxygen to that particular area, you might have problems with speech because your language center resides there. If you've got something going on in your occipital cerebellar region, you might present with gait instability, nausea, vomiting, maybe headache-like symptoms. So depending which particular area and region of the brain is affected is probably where you'll have the symptoms. Now, TIA is exactly what it is. TIA is transient ischemic attack, meaning they're transient neurologic symptoms that usually last 24 hours. Most of them will resolve within an hour of onset. Now, I always like to do some base research on the latest statistics because sometimes, things change so rapidly in the world of neurology that I'm always amazed by the statistics that I find. So according to the NASIT trial, which was the North American Symptomatic Carotid Endarterectomy trial, they say patients with their first ever TIA had a 90-day stroke risk of 20%. Now, if we think of how many people really present to their primary care physician or to an emergency department with TIA symptoms, they're very, very rare. They often go missed because they don't pay enough attention to think something acute may happen. And when they do present, unfortunately, it's a huge stroke. So that's something really to think about. And the way I like to explain TIA is if you look in this auditorium, it's a little bit harder because you can't find one single area of a bulb. But the brain is a rather dynamic organ which has millions of synapses, blood flow and oxygen. Everything needs to coordinate in a really well-functioned oil scheme, if you will, for me to speak, talk, interact, move, breathe without really making much effort about it. When there is a blood clot in a particular region, for example, my left frontal lobe, and I have stuttering speech that lasts a couple of minutes, that's a warning sign. So in a room where it's the bulb, if you will, if the bulb flickers, you might want to take a look and see, is it a switch default by switching it on and off, or is it the bulb? So if the switch works perfectly fine and you replace the bulb and your light's still flickering, you know probably there's some electrical outlet malfunction. So the brain is a rather dynamic organ in that it needs blood flow and oxygen, and there are several other circuits that connect the brain to the rest of the body, meaning your carotid arteries, meaning your heart. So if you had a transient symptom of speech difficulty and it was resolved, maybe you had a brief moment of cardiac arrhythmia, maybe you have carotid stenosis. And because your symptoms eluded in 5 minutes, you're not really out of the woods, but that's actually a warning sign you need to take a look a little bit further. So I think I'm a little jaded. This is the most beautiful organ in the body. This is just a beautiful pictorial to let you know. It's like a road map. Everything is housed with particular functions. So anytime you have a damage in the vascular territory, just like I said, you're going to have some very specific symptoms that you will experience. So in the world of neurology, a lot of you may have heard the word penumbra. Penumbra is just another word for brain tissue. What's happening in the penumbra is you have an occluded artery, which is that circular region right there. It's the area of infarction. And then you have your penumbra around it that you want to salvage. So really the goal in stroke is to salvage this surrounding tissue around the infarcted region. So you quickly want to restore blood flow and oxygen to that region to prevent further damage and injury to the brain. Does that make sense? Yeah, okay. And feel free to just, halt me and stop me if you have any questions along the line. So different kinds of strokes that we generally talk about. The two major kinds are ischemic strokes and hemorrhagic strokes. 71% of our strokes tend to be ischemic and 26 tend to be hemorrhagic. We'll talk a little bit further about each one of those. Just to show you a little bit of a pictorial, I have permission from the National Stroke Association to use this pictorial during education sessions, and this just drives home the point of what really is an ischemic stroke. So if you take a look, there's going to be a blood clot right there, and there's lots of blood flow and oxygen right here, but this distal end has no blood flow and oxygen. So if you look, that's going to be your core area of infarct. The penumbra around it is what you want to salvage, okay? Now, I'm not going to be talking much about stroke interventions today because that's a whole beast in its own, but here at the Primary Stroke Center, we have two procedures that we can do to remove clots that are called mechanical clot retrieval mechanisms. One is MRCI and the other one is penumbra. So for those people who have an ischemic stroke and we do not administer TPA, or they come with outside the window for us giving them TPA, we can mechanically remove this clot, okay? So that's what an ischemic stroke would be. And in comparison, a hemorrhagic stroke is exactly what it is. You have damage in the vasculature in or around the brain that causes the artery to burst, and then you have bleeding around the brain. All right, so breaking it down a little bit further for ischemic strokes, there are two different kinds. Embolic, meaning a clot that arises somewhere else in the body and travels up to the cerebrum, causing a stroke. And thrombotic is generally atherosclerosis related. So embolic, generally, they're very specific kind. They're either cardioembolic, meaning they arise in the heart and travel up to the brain, could be secondary to atrial fibrillation, which is an irregular heart rate, which is one of the largest risk factors for having a stroke. You could have congenital abnormalities such as atrial septal defect, ventral septal defect, And a very common one that we sometimes see in the world of stroke is also PFO. So the patent foraminal valley is a closure that happens shortly after birth. For some people, when this closure doesn't happen, what happens is it causes pooling and shunting of blood in the heart. Anytime there's stasis of blood flow in the heart and it congeals and forms a clot, puts you at a higher risk for having a stroke. And then left ventricular myopathy. The pumping muscle of the heart, if you will, for ejection is the ventricle. When you have uncontrolled high blood pressure and that muscle has been working really hard, it's going to get a little tired and stretched. Wouldn't work as well as it would, all right? So that would be left ventricular myopathy. And then atherosclerosis is generally related to plaque buildup in our arterial walls that can shower off and come off either through the aorta or any large vessels. And so those would be atherosclerotic, and they would be thrombotic in nature as well. Anybody care to comment on which population would have a fat embolus? No orthopedic nurses in the group? Yeah, okay. So fat would be your large bone fractures. Humerus, actually femur fractures would be your largest one. So that would be a risk. Air embolus? Nobody brave today? They didn't tell you there's going to be a closed book 50-question quiz before you're allowed to leave? Okay. So if I was in the Caribbean vacationing and I went on a scuba diving expedition, what happens when I go 15, 20,000 feet down exploring? There's an air pressure exchange there. Very easy to get an air embolus. Last year I did a presentation to my peers in labor and delivery and SHEP 5 nurses as well, and I came across a real cool research article about amniotic fluid, air embolus, post-delivery, which I thought was very interesting. And then foreign bodies, generally any catheter-related trips, foreign body-related mechanism that would occlude an arterial vascular region. And then obviously atherosclerosis we talked about. So generally when we have TIAs, we already talked, they tend to be warning signs that we can do something or the other about, and we'll talk a little bit about those a little later. Hemorrhagic strokes generally tend to be trauma-related. Depending on which region or the dura of the brain is damaged or injured is where you're going to have bleeding. Most commonly, we will see a subarachnoid hemorrhage secondary to a trauma or to an aneurysm. And what an aneurysm is, it's an outpouching of an arterial wall. Sometimes they tend to be very benign, depending on what kind of risk factors you have. If you have uncontrolled high blood pressure, the location of the aneurysm, you can have a hemorrhagic stroke from that. One of the big reasons we have ICH would be hypertension as well. We actually had a 77-year-old female patient that presented with a left frontal hemorrhage, and she presented with symptoms of right-sided weakness, and she had some expressive and receptive aphasia as well. A lot of times people who have atrial fibrillation and are on Coumadin therapy can have hemorrhagic strokes as well. AVMs are congenital malformations in the circulatory system, meaning you just have a tangle of arteries and veins. So what the arteries do is they take fresh blood and oxygen to the heart and lungs, and veins take it away. When you're missing that capillary bed over there, sometimes can cause you to have bleeding as well. Amyloid angiopathy, mostly you hear is a hallmark of Alzheimer's disease. What happens sometimes is when you have an overexpression of this protein, it damages the arterial walls and puts you at a higher risk for having a bleed. And then we have arteries that perfuse our brains, but we have veins as well. In the last couple of weeks, we've seen quite a few young people in their 20s and also in their 40s present with venous sinus thrombosis, and this is another type of stroke, very rare, that occur about 0.5 to 1% of our population, but we will see those as well. Any questions on that? Okay, all right. So what are some of the common signs and symptoms of strokes? We all know that, right? You might have speech deficit, you might have vision problems, numbness, sensory loss, you might have weakness. Generally, you wouldn't have a severe headache with a stroke, but sometimes it can be a classic marker for having like a thunderclap headache, which would kind of, predispose one to think that you might be having a bleeding kind of a stroke. All right. So there are some things we can do to prevent a stroke and some things that we can't. The non-modifiable risk factors would be your age. So the elderly or the young, depending on your risk factors, female, African American for race, ethnicity, and then family history as well. Things that we can do something about is primarily what we're going to focus about today, that I think every one of us should really know or have at least some resources and tools to be able to modify these risk factors. And we'll take a look at each one of these individually. And this was like a brusher up for me because my base is family nurse practitioner, and now I'm specializing in the world of neurology. So I had to do a lot of brushing up to do, because we always do the risk factor modification education, but really guidelines change every day in managing high blood pressure, diabetes, carotid stenosis, so this was a fun review for me as well. So hopefully everybody will walk away with something. So we have to inject a little bit of humor, because I always find in my role when I educate my patients, if I'm going to talk down to them, we're not really working together to help them be successful in their risk modification, because you need to give patients tools to have them succeed. So if we're going to tell them they have high blood pressure, we also need to educate them as to what they can do to modify that risk factor or control their blood pressure. So hypertension, one of the common causes of stroke, especially hemorrhagic strokes, undiagnosed or untreated hypertension leads to left ventricular hypertrophy, can lead to renal disease, congestive heart failure. A lot of times you see end organ damage from that, so arteries get damaged, your eyes get damaged, just a whole body-wide end organ damage that we see. 30% of people greater than age 60 will have a relative risk of having a stroke at least 4 times than a normal person who doesn't have hypertension. With treatment, you decrease the risk of their having a stroke by 38%. And about 60% of people greater than the age of 90 will have high blood pressure as well. Now, there have been several different trials that I won't highlight, but one that I'll mention, which is Progress, that kind of showed treatment of blood pressure incrementally in reducing systolic and diastolic numbers by small increments. So the first one is 9 and 4 decreases your risk of having an ischemic stroke by 24%, and then hemorrhagic stroke by up to 50%. And if you look at the numbers a little bit further, it reduces your risk by 36% for an ischemic stroke and 76% for a hemorrhagic stroke. And if we think about all those people that have uncontrolled high blood pressure and end up getting a hemorrhagic stroke, that's our 76% right here. So we have some basic guidelines as to, what we consider pre-hypertension, what's normal, and where we need to treat. So some of the numbers that you probably need to be very aware of when you're taking care of patients who have hypertension is where is normal and where is not normal. So systolic blood pressure less than 120, diastolic less than 80. You are pretty much in a treatment mode when you're at 140 to 159 and 90 to 99. So a lot of times when we look at hypertension in a primary care setting or even an acute setting, if they're not going to be taking any medications, you want to give them tools and resources as to what lifestyle management modification can they do to decrease their blood pressure, whether it's going to be diet controlled, whether it's going to be exercise mediated, where it's losing weight, or whether it's going to be in combination with medication therapy. Oops. The other risk factor that we have is diabetes. And I'm always amazed when I look at the national statistics. We have about 25.8 million children and adults in the US that have diabetes. When you look at the numbers broken down by how many are diagnosed versus undiagnosed and pre-diabetic, we're talking about millions. Just not thousands, just not hundreds, but quite a few. And for the year 2010, the statistics reported were 1.9 million new cases of diabetes. Now, anytime you have diabetes, you have a 2 to 4 times increased risk of having a stroke. So things to know about blood glucose levels would be what would be normal fasting versus a casual. You always have to remember, if you end up going to one of the screenings, that's just what it is. It's a screening tool that shows you in that snapshot of a moment, do you have an elevated blood glucose? Are you at risk for diabetes, or do you have diabetes at that point in time? So for those of us that look at hemoglobin A1C, the glycosylated hemoglobin, there are a couple of different recommendations based on who you look at, whether you look at the American Heart Association or you look at the American Association of the Clinical Endocrinologists, because it's a little bit of a sliding scale, a slippery slope, because you don't want to go too low because it puts you at a higher risk for having cardiac events. You just want to stay at that median. So depending what your stroke risk factors are, the goal that the American Diabetes Association recommends is less than 7.0%. I recently had a gentleman that presented to us with a 52-year-old, actually, with a left MCA stroke. He actually presented with symptoms of dysarthria and right arm weakness, and he had a history of hypertension and diabetes, and his hemoglobin A1C was 11.6. So there's, a little bit of education. And he was already taking insulin, but not really monitoring his blood glucose levels at all. So that was like a huge moment of teaching of how important it is for him to manage his diabetes to further reduce risk of an additional stroke in the future as well. Okay. So talking about diabetes, I do have to mention, as a primary stroke risk, as a primary stroke center here, we are partaking in the IRIS trial, which is an insulin-resistant intervention trial after stroke. And I was just checking with our research coordinator, Kathy Gregory. We actually are now clocking 63 patients in the study, where our site is amidst the top 10%, and several 100 hospitals nationwide and worldwide are partaking in this study as well. So just interesting to kind of be aware of what else is going on that puts you at risk for having an ischemic stroke. And the purpose of the study is actually to determine the effectiveness of a TZD medication often used in the world of diabetes compared with a placebo, to see if there is any risk-benefit ratio of using the medication. And primarily what it is, it's looking for if you have any insulin resistance that would put you at a higher risk for having stroke. Had anybody heard of the IRIS trial before? No? Okay. So pretty cool to kind of Google up and see if you're further interested in the trial and stuff like that. So wonderful. We always have to play good cop, bad cop, and always appreciate the humor. I was looking at the last name and I totally missed the HDL and the LDL because I'm like, must be the date of birth, or you're kind of looking for some funky stuff. So let's break this down and take a look, because dyslipidemia is another risk factor for stroke as well. And so what do all these numbers mean anyways, okay? So total cholesterol, you want to be at less than 200. LDL, which is your bad cholesterol, you want it less than 100. And once your numbers climb up, you know where it is you belong here. And then your good cholesterol needs to be, it needs to be less than 40 is low and greater than 60. So anywhere between 40 and 60 is where you want to be. And then triglycerides, you want them to be less than 150 as well. How many people in this room know what their cholesterol is, just at a baseline level? Excellent. Wonderful. And yet nobody has heard of the stroke risk card. Okay. All right. So what happens with dyslipidemia is there's a tool by the National Cholesterol Education Program that helps to evaluate what kind of risk factors you have that would guide and govern where it is your cholesterol sits. So a lot of times, based on what other comorbid factors you have, like if you have symptomatic carotid disease, if you have peripheral arterial disease secondary to diabetes, if you have an aneurysm, and what other risk factors you would have, such as cigarette smoking, hypertension, family history. Some of these modifiable risk factors, initially you would do lifestyle changes. and modification. And then based on where you fall in the risk scorecard is where treatment would come into play for you. So generally, the first line of recommendation would be to make healthy lifestyle changes. And then in spite of that, because of genetic factors or other comorbidities, you might need medications to help drive that cholesterol down. So I just wanted to bring to your attention here, when you look at the computed data, your 10-year risk, if it's greater than 20%, your bad cholesterol, you really want it to be less than 100. Now, for anybody who's got coronary artery disease, who's had an MI, who's had a stroke, we generally recommend you want them to be less than 70, okay? And once again, it just shows where your levels are. If you can make some therapeutic lifestyle changes, dietary-wise, exercise-wise, lose some weight. If your LDL drops, then you're doing really well. Unfortunately, for some people who work really hard but just cannot bring it down, then we try to initiate some pharmacological interventions for them. So this is very interesting. How many of us as nurses listen to hearts and lungs? And every now and then we'll catch an irregular heart rate that just didn't quite sound like an oink oink, right? Wasn't that lub-dub that we're kind of used to listening with our ears. And so another huge risk factor for stroke is atrial fibrillation. And what happens with atrial fibrillation is you have fibrillatory in the left atrium. Anytime there is pooling and stasis of blood, you can have a thrombus, shoot it out somewhere up there, travels all the way up there, end up having pretty much a wedge-shaped cortical infarct in that region right there. So what's the prevalence of atrial fib in our population? About 2.2 million people. And atrial fibrillation causes about 60,000 of our strokes, most prevalent in the elderly, almost 5%, and greater than 70 years of age. And quarter of our elderly population older than 80 will present with atrial fibrillation. Research is showing treatment with warfarin reduces strokes by about 45%. The recommendations from the American College of Cardiology is they recommend anticoagulation with warfarin for patients who are greater than 60 years with a history of diabetes, coronary artery disease, CHF, and thromboembolism, and for all patients over the age of 75 as well. So it's very interesting. Early in the year, I attended the International Stroke Conference in Los Angeles, and I sat into one of the recommendations about anticoagulation in the elderly. And a lot of times we will see a lot of hesitancy in this age population of 75 years and older because we're always thinking that they will be at a higher risk for bleeding. And actually the recommendations that they put forth is the risk of them falling multiple times to actually have severe bleeding secondary to being on Coumadin is not as high as we think it is. So they would actually benefit from being on Coumadin therapy. Now, if they're unable to take anti-oral coagulations for whatever reason, then it's recommended that, if they're able to tolerate aspirin, then you can do aspirin. And then also, what are we doing with atrial fibrillation? It's an irregular arrhythmia of the heart. So the more sinus rhythm you stay in, the less risk you will have to at having a cardioembolic event resulting in a stroke. So for these patients, if they're able to tolerate, we can also go the antiarrhythmic and beta blocker route as well. So the lady that I mentioned earlier, the 77-year-old with a left frontal hemorrhage, actually declared with AFib 4 days into her study. Given her intracranial hemorrhage, she was safe enough to start aspirin at a full dose. However, Coumadin was not really recommended for the next 2 weeks. So when cardiology consulted with her, they actually recommended, we had already started her on metoprolol 25 BID for rate control, but they also recommended Multac, which is an antiarrhythmic, for additional rate control to keep her as much in normal sinus rhythm as well. All right. So carotid stenosis, this is another huge culprit that we have for strokes. Approximately 5 to 10% of our elderly population greater than the age of 65 will have asymptomatic carotid stenosis. They actually cause about 8 to 11% of our strokes, and the two big trials that we kind of refer to back and forth are the NEST and the CREST trials. And they actually talk about the differences between carotid endarterectomy and carotid artery stenting. and the grading criteria to see how critical the stenosis is usually the NACIT criteria. So anytime we talk about people having carotid stenosis, they'll either be deemed as severe, meaning 70 to 99%, moderate 50 to 69%, and then less than 50%. Now, depending on the severity of the stenosis and depending whether they're symptomatic and they've had an acute infarct is what's going to drive their treatment. So the recommendations generally are if they've had a recent TIA or an ischemic stroke, then we would, with severe stenosis, then carotid endarterectomy is recommended as far as treatment options. And then moderate, once again, depending on the patient's specific risk factors, age, gender, comorbidities, and severity, that's going to drive your treatment protocol there as well. Generally, if they're asymptomatic and you just happen to find that on a carotid ultrasound or within a workup, generally less than 50%, you would probably just monitor them on interval levels until and unless they were symptomatic, you wouldn't necessarily do anything. And then obviously if you're symptomatic, then at 80% or greater, then you want to intervene. Now, interestingly, at the stroke conference as well, the data was reflective actually for the elderly people. They were actually recommending carotid endarterectomy versus stenting, meaning their outcomes, depending on medical management and surgical interventions, depending on their other risk factors, carotid endarterectomy was actually recommended for the elderly because they tended to do really well with that. Just this past week with one of my attendings, I was in clinic and I had the pleasure of taking care of a 56-year-old male patient who came in with a right MCA stroke with left-sided symptoms of weakness of his arm and leg and speech dysarthria as well. His NIH stroke scale when he came to us was 6. And he got TPA at the outside hospital and came to us. His risk factors specifically were history of smoking, no other significant medical history, and in his workup he actually had bilateral carotid artery stenosis. The right one was 90% and the left one was pretty much occluded as well. So given his stroke, he was stable enough to get one of his carotids fixed, and he came back I think about a month after rehabbing to get the other side fixed as well. And he's doing quite well, and he quit smoking as well. And the only 2 medications he's currently on is aspirin and a statin medication. So that was pretty interesting as well. So just to give you a little bit of a pictorial, what we mean when we talk about carotid stenting is there's your carotid right there. You see that culprit is your plaque formation right here, and there's your stent that's deployed right there. All right. Now, any of these procedures, as we know, don't come without risks either in trying to deploy the stent here. You might shower a few, arthrosclerotic particles in there, but generally the procedure is tolerated quite well. And then endarterectomy is just what it is. It's the incision of the carotid artery, remove the plaque, and then repair the artery. Okay. And then we also have other risk factors such as hypercoagulable status that we kind of think about as well that put people at a high risk as well. In the African American population in larger cities, you tend to see sickle cell disease very commonly. So when you have, your red blood cells that are a little bit diseased, you end up having a little bit of dehydration, you have joint pain. A lot of these people are at a higher risk for having strokes. You want to make sure that, if you come across your patient population that has sickle cell disease, you're hydrating them and preventing any hypercoagulable status that would cause them to have a stroke. Factor V Leiden is your clotting protein CNS as well. Smoking and birth control use as well for women, especially if you're age 35 and you're a smoker and you're taking birth control pills, you're at a higher risk for having DVTs, blood clots that could then result in you having a stroke as well. Hormone replacement therapy, a little bit of research on that. So, postmenopausal use of estrogen, a lot of times if you still have your intact ovary and uterus and you have a little bit of extra estrogen, that puts you a little bit more hypercoagulable, meaning your blood's going to be a little bit thicker, sludgier, and pool around, puts you at a higher risk for having stroke. So we kind of take a big brunt here for being women, right? Because you see pregnancy, postpartum, and preeclampsia. So pregnancy, you have a hemodynamic shift that happens in your first trimester, you balance out in the second, and then the third trimester, it puts you at a higher risk. Postpartum women, 2.6% higher risk of you having a stroke because of the hypercoagulability that happens in that first week while you're trying to get back into your homeostasis balance after giving delivery. And then preeclampsia with the uncontrolled hypertension puts you at an increased risk for having a stroke as well. Any questions? Okay. All right. So, we banned smoking yet, or are we still working on it? They kind of go hand in hand. It's always hard to find one pictorial that gives you the humor that please don't smoke and please don't drink, but I thought this did it quite well. So 2 times higher risk of having an ischemic stroke if you're a smoker. And alcoholics greater than 5, you have a 69% increase of having a stroke. Now we all know that research is showing a glass of red wine because of its antioxidants, its flavonoids, its help in increasing our good cholesterol is okay. But once again, the message here is moderation, not the entire bottle of the red wine. And then some of the current dietary recommendations are 1 drink per day for women and 2 drinks per day and 0 cigarettes, I think. So since I'm a fish and I'm not a drinker, I always have to look and see, as far as the alcohol, what are the guidelines. So 14 grams of alcohol, meaning 12 ounces of beer, 5 ounces of wine, and 1.5 ounce of hard liquor. Right now we have a very young guy with us here. He's 46 years old. He's only positive post-medical history, is chronic low back pain, and he is a smoker and almost a 6-pack, if not more, of a drinker. And he's got a cerebellar stroke, and he's being worked up for myopathy. So it's really hard when you have these kind of patients who end up having stroke and you have the opportunity to intervene and educate where it is you're going to make a big difference in trying to help them make those healthy lifestyle choices that they can work towards as well. And then this is huge, lifestyle modification. So I was at my nurse practitioners a couple of weeks ago and just talking about how stressed life is, and I tend to be a Bikram yoga fanatic, but when my life gets busy, I don't have that luxury of giving myself 90 minutes of doing that exercise time. And when I mentioned to her, well, I'm very busy, I'm not sedentary, she had to do a timeout for me and remind me as the nurse practitioner what the recommendations and guidelines are. It doesn't mean if I'm a nurse and I work 8 hours, if you're a clinician and you work 8, 10, 12 hours in your feet all day, that's not exercise because you're walking. You can count your pedometer and see how many steps you've acquired during the day, but really the recommendations are 2 hours and 30 minutes, a total of 150 of moderate intensity aerobic activity every week, and some sort of muscle strengthening exercise as well. And the big thing here is, I'm always amazed how much screen time our kids spend. And we'll talk a little bit about obesity and some of those numbers and why this physical inactivity is so important, because stroke doesn't just happen in the elderly anymore. It's happening in the young, and it's also happening in kids as well. So those are some of those recommendations we need to be mindful of. And then protective effects of physical activity on stroke: mood elevation, weight loss, moving around, managing our blood pressure and stuff like that. So quite a few dynamic effects of physical activity on our overall well-being while reducing our stroke risk factor as well. So anybody into kayaking? I'm going to be on my first adventure on a kayak this weekend, and when I came across this, that's going to be me. Hopefully not. How often do you find something that just says what it is you want them to say? Very rarely. So lifestyle modification and obesity. And so once again, the statistics that glare at us are quite mind-boggling. 1/3 of our population is obese for adults. 17% of our children are obese. The obesity rates are not going down, they're actually doubling and tripling for our children. So it's projected 1.5 billion obese and overweight people will be tracking by the year 2015. So there really isn't time to be, reactive in 2015. We need to be proactive starting now to make all these lifestyle modification changes. So we're hopefully not getting to 2015 with these numbers, but we're hopefully going to reduce them. And then look at the medical cost of obesity, $147 billion. Healthcare reform needs so much money. There are so many uninsured people across the nation, and look where our money is going. So, and obesity is one of those independent stroke risk factors that then attributes to hypertension, diabetes, and dyslipidemia that puts you at an increased risk for having a stroke. For those of us that are table and number driven, these are some of the numbers you need to be aware of where obesity lies. And based on your height and weight, it's always a good idea to know where you exist in this BMI to know what your risk factors are as well. And the reason I say that is that number means something, but really the abdominal obesity is what we want to really worry about. So for men, it's waist circumference greater than 40 inches, and for women, it's greater than 35. So unless I'm going for dress fitting, if anybody comes close to me with that measuring tape or even headed towards my waist, it's going to be like a massacre flowing. But generally, anytime you have abdominal fat tissue accumulation, we all know that. Everybody jokes and calls it the menopause. Everybody jokes and calls it the beer gut belly. But what does it put you at risk for? How many of us have heard of the metabolic syndrome? Right? Now there's this whole new term of diabetes. So anytime you have high blood pressure, you have high lipid levels, add to that your central obesity, it just puts you at a higher risk for so much more that you have to then battle with. So having said that, here's a little bit of a pictorial of looking at where we need to make some nutritional choices. What are our portion sizes in our society today? We're existing on a supersized menu, aren't we? I came across a really cool website. A lot of you guys can Google it up. It's called uk.gov, and it shows you your platter portion, and it's called your Eat Well plate. And it shows you a pictorial of what your portion servings are supposed to be in proportion to where you should be with all your eating, your grains, your vegetables, fruits, milk, and beans. And I'll be the first one to admit, if I'm having a busy day, I'm going to reach for that bar of chocolate because I need a little bit of a glycemic bump, whereas I probably will reach for my apple later during the day, not quite early. So just a little bit of a pictorial to see where it is we need to be with our nutrition. So, stroke can be devastating. And, an ounce of, prevention is worth a pound of cure. I think it was Benjamin Franklin who said that. I think, yeah. So stroke can be quite devastating, and we have elderly patients that come in, they're 82, 87, they're mentally intact with their faculties, they're living independently, they have a stroke, they cannot go home because they're hemiparetic, they cannot walk without assistance, they need help getting dressed, they may have speech problems, they may have depression. And now they go from independent living and taking care of themselves to living in either a nursing home or being dependent on caretakers to take care of them. So I think as nurses, we do a wonderful job. Scientific statements, organizational statements come out when, the world of medicine becomes reactive. We as nurses need to be really proactive, meaning we need to empower ourselves with education so we can educate our patients, so we can prevent strokes. Didn't realize I had snuck it in there. I'm so smart, I just told you about that before. Now here at Fletcher Allen, we use the FAST algorithm that most of you are aware of, and that's the face, arm, speech, time. And that's the quintessential scale that everybody should know, whether you're inpatient, outpatient, even in your personal lives, to know that, need to know what the deficits and changes are. And then your time is so important, meaning if it's an ischemic stroke, we may be able to intervene with a thrombolytic medication, but we need to have you here in a timely manner, most likely within 3 hours and maybe 4.5 if you fit a certain criteria to get thrombolytics that late. All right, so I'm going to hand out a few things because I had quite a show of hands about not knowing about Life Simple 7. And Life Simple 7 is an American Heart Association So Life Simple 7 is exactly what it is. 7 simple steps and 7 simple tools endorsed by the American Heart Association and the American Stroke Association to get active, control your cholesterol, eat better, manage your blood pressure, lose weight, reduce your blood sugar, and stop smoking. So the really cool thing about this is you can actually go on the website and kind of take this tool that then gives you sort of your assessment of where you are. It'll ask you a couple of questions and ask you if you know what your cholesterol is, if you know where your blood pressure is, what kind of a diet you have. So it'll kind of give you an algorithm. If you're not eating too many fruits and vegetables, it'll give you some recommendations where you can kind of bring it up. And then obviously smoking cessation would be another big one too. And what it does, it gives you a heart score as where you are as far as your heart health goes. So I would recommend that you kind of check this out. You can kind of track it over time. So if you happen to go to your primary care physician, if you have a loved one who's experienced a stroke and they have some modification risk factors, you can kind of track it online. It's a great tool for yourself too, to keep a track of and just know where do you check in life, because it's very simple. Simple steps that we can take every single day to be healthy and to prevent a stroke. Now, I apologize, the clarity of the stroke risk card is not very clean on the screen, but once again, this is a card that's endorsed by the National Stroke Association, and it just gives you a red, a yellow, and a green. So if you're high risk, you're going to fall in that red line. You need to pay attention to your cholesterol, diabetes, smoking, if you have atrial fibrillation, where's your diet as far as your BMI and obesity goes, and do you exercise or not, and then do you have a family history of stroke. So once again, it kind of behooves you, and if you were really paying attention, there's nothing new that you're hearing today. These are all things that we do to prevent chronic diseases such as diabetes, renal failure, prevent myocardial infarctions, keep people's heart healthy. What I'm trying to pledge to you here is the brain is just an important organ. We need to prevent strokes too. So prevention is really what we're headed for here. And you can help prevent a stroke because now you know how. So I just wanted to bring to your attention that the stroke team and the neuroscience nurses from McClure 6 have been very busy this month. We've had a fun month of educational activities where nursing staff have really gone outside and above and beyond their duties of being a bedside nurse to projecting to the community by doing a stroke poster presentation outside the Fry Moyer Center. They actually also extended themselves and did a community dinner event at the Vermont Respite Home. You can see right here is our very own, very quiet Dr. Chris Komischow helping doing the dishes, and I understand he was requested to come back next year because the dishes were spotless. And then And then right up here is we have a collaborative joint effort that we did at the food shelf this year with the American Heart Association, the Vermont Department of Health, and the food shelf, and we did a cholesterol screening in the community as well. And right here at the core is our other stroke attending, Dr. Gorman, providing some doctor in the house consultation. So what we did is we did the Life Simple 7 and we did the stroke risk cards. We did cholesterol screening and blood glucose screening as well, and then did some stroke prevention education, risk modification education as well. So we're kind of hoping that we're trying to reach out within the community and spread education not only amongst us, but the big deficit we find in people who don't recognize TIA as a warning sign is because they do not have the education for it. Neither do they know what kind of risk factors they can modify to prevent a stroke. So I think if every one of us is aware of what our stroke risk factors are, we're diligent in taking care of ourselves, our loved ones, and our patients, I think those stroke numbers and those incidents and the prevalence will definitely decline. Thank you. Any questions? Yes.